Hi everyone, thank you so much for joining this neuro tutorial. So today's tutorial is on stroke syndromes and it's given to us by Dr. Sanskrithi. So just a few rules. For those of you that are watching via Zoom, if you just want to put any questions or comments for things that are covered in the moment, if you just want to pop it into the chat, and any questions I can wait to the end if you just want to pop it into the Q&A. If you're watching on the Facebook Live, just comment your questions or comments and I'll pass them on to the tutor. That's all from me now, and I'll hand over to Sanskrithi. Thank you.
Hi everyone, hi, it's Sanskrithi again. I'm one of the F1 doctors at Lister Hospital and I'm doing an AFP in clinical neurosciences at Cambridge. Today's tutorial is about stroke syndromes. This is part of a little series that I'm doing with becoming a doctor in neurology and neurosurgery. So today's tutorial is mainly going to cover things that will help you recognize various stroke syndromes. I'm not going to go too much into the management. So with that, let's get started. This is just a disclaimer about kind of this being just a tutorial and not medical advice. And these are our learning objectives. We're going to be defining a stroke. We're going to look at what pertinent points we need to ask in when we're taking a history from a potential stroke patient. And we're going to go through a few kind of different stroke syndromes that come up in exams quite often. By no means have I covered all of them. There's loads of niche ones that you can go and cover. You can look them up on Google. But I've chosen to talk about the things that come up the most in exams. Okay? So when we start off, we need to define what we're talking about. What is a stroke? Any ideas from anyone at this point? Just pop it in the chat, that's fine. I'll wait about a minute for answers. No suggestions. Loss of perfusion to an area in the brain, perfect. Focal neurodeficit lasting more than 24 hours, good. We're getting there. A couple more. All right, everyone's a bit shy at the moment, that's okay. Let's go on. So, I think we have a poll for this, actually. Oops. So you can start choosing which ones are right. Okay, keep going. All right, a few more seconds to allow at least a few more people to vote. Okay, great. So many of you might be confused by what the answer is here, and a lot of people have chosen 3, which is absolutely correct. But also 1, so A, B, and C are all correct. So stroke is a clinical syndrome, and it involves a rapid onset of neurological symptoms, as someone already said in the chat, and it is caused by an abnormality in the vascular flow to the parenchyma. And the symptoms do not resolve in 24 hours. That has a different name called a TIA. So all 3 of the first phrases are correct. They're all true. So a stroke is a clinical syndrome of rapid onset neurological symptoms, usually focal, as one of the attendees said, lasting more than 24 hours with a vascular cause. TIA is identical. It also has a vascular cause. It is also rapid onset, but it usually resolves within 24 hours completely. Okay, now that we have that base, we can talk about what things we can ask while taking a history. So the thing that you do with any patient is make sure that they're oriented to time, place, and person. And you also want to know when they were last seen normal and when they were last known well. So you want to know what at what time the onset was. And this gives you an idea of whether this was an acute onset or how long it took to develop. Then you can think about the severity of the deficit, so severity of the weakness or the sensory disturbance, visual or speech and language disturbance. Okay, the course of it. So how did the symptoms evolve? Did they come on slowly? Did they come on rapidly? So with strokes and TIAs, you know that it's a rapid onset of clinical symptoms. So you want to differentiate from your other differential diagnoses, yes? Precipitating symptoms. So most cases have none. Most cases have risk factors that may lead to someone having a stroke. But there are cases where trauma can cause a stroke. So you want to know if that was the case. And any associated features. So if the patient has a headache, nausea, vomiting, or neck stiffness, you're thinking maybe of other differentials which may lead to, which may make you think of raised ICP. It could be a subarachnoid hemorrhage, which is also a kind of stroke. Or it could be, if you're thinking neck stiffness, kind of light intolerance, it could be something else. It could be signs of meningism. So just think about what other symptoms the patient has. Do they have a unilateral headache? So a good stroke mimic is a migraine. There are things called hemiplegic migraines, which are severe migraines that cause symptoms that are similar to a stroke with motor weakness and sensory problems. So look out for any headaches that a patient might have. Fevers. So fevers might point you to how the stroke came about. So the fever could be a septic emboli flying off from maybe the heart, where there's a heart valve defect or something like that. So think about that. Think about the cause of the stroke. Is there nausea, vomiting, and dizziness? So this could give you an idea about what the location of the stroke is. So it could be a posterior circulation stroke with these kinds of symptoms. And palpitations. As you know, atrial fibrillation can cause emboli, thrombus, and then emboli, and that could be a source of the stroke. So thinking about causes. Previous episodes, so previous TIAs can increase the risk of having a stroke, and previous strokes means that this patient is a vascular path. So they also have risk factors. They're also risk factors, and they might have other risk factors for having a stroke. So just thinking about the whole picture here. And asking about the dominant hand of the patient in any neuro case, it's worth asking which hand is more dominant in their day-to-day activities. Does anyone know why this might be important? Feel free to just type into the chat. Tells you which side their dominant hemisphere. Yeah, perfect. So right-handed people mostly have a which side dominant hemisphere? Any guesses? Left. Perfect. So that gives you an idea of what deficits the stroke may give. Okay. And then thinking about key stroke symptoms, what you might be looking out for. Weaknesses, so motor weaknesses, sensory disturbances, visual disturbances, speech, as I've already said, ataxia. So that's movement and proprioception dysfunction, dysphagia, inability to swallow, or problems with swallowing, reduced level of consciousness, and pain. And when you have pain, use your Socrates method to take a further history on that. And finally, here's a whole list of risk factors. Ischemic heart disease, obviously that means that there are vascular path, hypertension. So I will come on to this, there are two types of strokes. There's the ischemic stroke and the hemorrhagic stroke. Okay, and hypertension increases the pressures within the blood vessels, and that can put you at a higher risk of hemorrhagic strokes. And all the other things you can see that they mainly kind of overlap with having any ischemic cardiac event as well. So the risk factors overlap with cardiovascular risk factors. And any hypercoagulable states or issues like atrial fibrillation and so on. Okay. And finally, onto stroke syndromes. To understand the stroke symptoms, you need to understand the anatomy of the brain vasculature. So let's do a quick knowledge check. I'll ask everyone to please write down the names of 1, 2, and 3, please. You need to write down what artery it is. Brilliant, keep it coming. Okay, great, so brilliant. So we've got a few answers. 1 is anterior cerebral artery, perfect. 2 is internal carotid, someone says, and then 3 is posterior cerebral artery. And then we have another for 3, middle cerebral artery. So first of all, this is a circle of Willis. Most people have an incomplete circle of Willis. It's pretty common to have an incomplete one, but it's well known to be a complete loop where there are arteries that can take over if a particular artery is blocked. Okay. Going on to what is 1, I think everyone who's written down the answer is correct. So it is the anterior cerebral artery. Number 2 is middle cerebral artery. Number 3 is posterior. Okay, and then the next ones 4, 5, and 6, and 7 as well. Please write down the answers. I'd like as many answers as possible, please. For anterior communicating. Brilliant. Keep them coming. Okay, 5, posterior communicating, and 6 is basilar, someone says. Perfect, there is consensus. And 7, vertebral. Perfect. Well done, guys. So 4 is anterior communicating, 5, posterior communicating, 6 is basilar, it's the main one that runs down the middle, and then vertebral arteries on both sides. So this is just one side and there's a parallel one on the other side. And there's various smaller branches coming off. You can see the annotations there. Okay, why is it important? So the various different arteries supply different regions of the brain, and they all have particular regions that they supply to. For example, the MCA, as you can see, it's in red over here, it supplies all of this region. In fact, MCA probably supplies one of the biggest areas of the brain. It covers a lot. So a stroke there can be quite devastating. Whereas in the medial, in the middle of the brain, ACA covers a lot of it, as you can see over here on the left-hand image, and posterior covers the posterior aspects, of like where the optics and sight are all computed. Okay. About 2/3 of all ischemic strokes happen in the middle cerebral artery territory. And it, as I said, it can cover a lot of areas. So it can cover frontal, temporal, and parietal lobe. So it can be quite devastating. And also, when you're thinking about strokes and what their effects are, think of the homunculus. I'm sure you've done this in neuroanatomy at some point. So ACA strokes are more likely to affect the feet and toes, and MCA are more likely to affect the hands and the face and the mouth. Okay, I hope that makes sense. So as I said before, there's two types of strokes. There's ischemic, which is most common. Around 85% of strokes are ischemic strokes, and hemorrhagic strokes. Around 10 to 15% of strokes are hemorrhagic. And I've given you different types and different causes of it. So ischemic can come from an embolus or a thrombus, systemic hypoperfusion. So that could be when, for example, there is vasospasm. That can occur when someone's taken a lot of cocaine, for example. That usually happens in the heart, but it can also happen in the brain. So vasospasm can cause hypoperfusion. Other causes could also be shock when you're third spacing all your fluids, and there's systemic hypoperfusion. Okay, and then clots in the venous circulation, so venous sinus thrombosis can also be a cause of ischemic stroke. And finally, hemorrhagic, there can be intracerebral hemorrhages, so within the parenchyma of the brain. This usually happens with hypertension, and then subarachnoid hemorrhages as well, that I'm sure you guys have come across before. So for ischemic strokes, there is something called the Bamford classification about how you can think about classifying the different types of strokes. So there's Hello, can you all still hear me? Yeah, great, okay. So moving on, so total anterior and partial anterior, so they form the strokes in the anterior circulation, which include the anterior cerebral artery and the middle cerebral artery. For a total anterior stroke, you need all three of these symptoms that I've stated here. So you need your unilateral weakness of the face, arm, and leg, a homonymous hemianopia, and a higher cerebral dysfunction. So it could either be dysphasia or visuospatial. Whereas for a partial anterior stroke, so it involves either one of the ACA or MCA, and you only need two of these. So that's essentially a partial stroke, okay? Lacunar strokes are interesting where these are kind of, you can almost think of them as micro strokes in the parenchyma of the brain. These usually affect the basal ganglia, which is quite common, or the thalamus, for example. And it's usually the smaller kind of blood vessels that are affected. Some people might have small lacunar strokes that have no effect. Over a period of time, the brain has kind of found other ways to compensate. And it's quite common when you CT a really old person. For example, I'm on trauma and orthopedics at the moment, and old people fall all the time, come in with broken hips, and we do a CT head to see if they've hit their head and caused a bleed in their brain. And we often find old lacunar infarcts that didn't really give a huge amount of deficit. So that these are very small strokes, but sometimes with a big enough stroke, you can get a pure motor deficit a pure sensory deficit or a pure sensory motor deficit. So you don't get a higher cerebral function. You might not get a hemianopia, but you just get these particular small deficits in these people. Okay, and then finally the posterior circulation stroke. So you can think about what kind of things are at the back of your brain. So your you've got your visual cortex there, you've got your brainstem, you've got the cerebellum. So any of these can be affected. So you need one of either a cranial nerve palsy, bilateral motor or sensory deficit. So remember where your pathways converge and all go down the midbrain, pons and medulla. So those can be affected. Conjugate eye movement, cerebral dysfunction, or isolated homonymous hemianopia. All right. So this is the way you can classify ischemic strokes. Is lacunar stroke the most common ones that presents in patients? I would say the big strokes, the MCA strokes, for example, partial anteriors, are probably the most common. I would say that the lacunar strokes are probably more common in number, but also go undetected sometimes because the motor or sensory deficit might be so small that you don't notice it. As I said, I'm seeing right now in patients, most patients that come in don't really have a huge motor or sensory deficit, but they all tend to have kind of old lacunar strokes. So by sheer numbers, I think lacunar strokes are probably most common. But in terms of presentations that you get in a stroke ward or into A&E, it's probably the partial anterior circulation strokes, specifically the MCA strokes, that come up most commonly. Okay, I hope that answers the questions. All right. So strokes elsewhere, the whole brain is vascularized. So any blockage in any artery can cause a stroke. There are plenty of different stroke syndromes, but I'm only going to go through a few. I've put down all the information on here, and I won't go through it too much because they can be confusing and you need to wrap your head around them slowly by going through the neuroanatomy and thinking of what symptoms each can cause, but I've put them all here. So we're going to be thinking about the midbrain, pons, and medulla strokes, so one of each. So a midbrain stroke is also called a Weber syndrome. This can be caused by ischemia of the posterior cerebral artery or any penetrating midbrain branches. And this is on the medial ventral midbrain. So wrap your head around that. So medial means in the middle, ventral means towards your mouth. I always think of it as if I'm venting to my friends about something, it comes out of my mouth, so it's on the front of me. And then it's in the midbrain. Okay, so any problems over there can cause you a contralateral weakness because of effects on the corticospinal tract and an ipsilateral lateral gaze weakness because of the effects on cranial nerve 3. So what you need to do after this tutorial is sit down with your neuroanatomy textbook and kind of just make sense of this, because right now it's quite difficult and I understand that. So in the pons, we're going to be talking about the basilar artery stroke. So we talked about the basilar artery earlier. It's a huge artery that combines together with the vertebral arteries to form branches into the circle of Willis. So a ventral pontine stroke is also called a Millard-Gubler stroke. We're trying to move away from eponyms. I think it's best to keep it anatomical, so just call it ventral pontine stroke. And these are the effects that can cause a contralateral weakness because of effects on the pyramidal tract, an ipsilateral lateral gaze weakness because of effects on cranial nerve 6, and ipsilateral weakness on the face because of cranial nerve 7 effects. Okay. And then finally, we have a Wallenberg syndrome, which is a lateral medullary syndrome. They both mean the same things. You might on PassMed or elsewhere come across it being called both Wallenberg and lateral medullary syndrome, so don't be confused, they're both the same thing. And it's most commonly a blockage in the vertebral artery or posterior inferior cerebral artery, also known as PICA. And as you can see, it can cause a lot of effects. So I think the best thing to do, as I said earlier, is to think about the anatomy and think about the vasculature that's supplying to the anatomy, and think about what happens when I just shut it all off in that particular region. And the answers are easy to think of after that. Okay, let's do a few questions and we can discuss a few cases as well. So I'm going to start the poll. Sorry, is it posterior inferior cerebral or cerebellar? Posterior inferior cerebellar artery PICA. Okay, let's see if I can start the poll. Okay, cool. So we discussed this in the roughly what proportion of all strokes are ischemic rather than hemorrhagic? Okay, I've got 9 votes out of 23. I'd like a few more. Okay, I'm going to give 5 seconds for people to answer. All right, okay, let's end the poll there. So the answer is D, 85 to 90, which most people have selected. So ischemic strokes are the most common of both types of strokes. Hemorrhagic are around 10 to 15%. So well done to everyone who got that right. Okay, let's do a few cases. So I'm going to read the case out and let's think about it together, okay? 65-year-old right-handed woman, okay, so we've got the dominance there, developed a sudden inability to speak properly while she was talking to her neighbor. Her husband brought her to hospital immediately and described the problem as if she were talking double Dutch. Her past medical history comprised hypertension and osteoarthritis. She was taking bendraflumethiazide and codeine. On examination, there was an obvious word-finding difficulty and problems correctly naming objects. Okay. Understanding appeared to be intact. Her blood pressure was 190 over 100. There was no other abnormality on examination. So, what are the risk factors in this patient's history? What can we see in her past medical or kind of her case that make you think that she's at higher risk of strokes? Okay, I'd like a few answers before I continue, if that's okay. Just want to make sure everyone's on the same page. Nope, just, okay, cool. Brilliant, well done. So hypertension, for sure. Hypertension is definitely one of the risk factors here. And someone else said age, perfect. So the older people tend to be at a higher risk of strokes and cardiovascular events as well, just because of how their blood vessels have aged over the years. So absolutely correct. So she was taking good. So that's about it. Arthritis, I'm not really sure. That probably shows that she's old and therefore at a higher risk for stroke. Good job, everyone. So what kind of stroke has she had? Let's think about the 2 main types of stroke and which one do you think she's had? Okay, I have one ischemic. Okay, so let's just think between ischemic and hemorrhagic first, and then we can think about what's happened after. Okay, so I have a couple of guesses saying total anterior and partial anterior. This lady has hypertension. She could have had a hemorrhagic stroke just from the history that we have. Equally, just by sheer numbers, she could have had an ischemic stroke because that is the most likely kind of stroke that patient can have. And if she has had an ischemic stroke, then we can classify if it's total, partial, lacuna, or posterior circulation, because remember the Bamford classification is for ischemic strokes. Okay, so hypertension. So one guess I have is hypertension, likely thrombus. So hypertension can cause a thrombus. So thrombus is essentially a clot, right? So when you have turbulent flow, such as an AF, or you have a hypercoagulable state, such as in sickle cell or polycythemia, where there's just more stuff in the blood than just kind of general fluid. There's more cells in the blood, or weirdly shaped cells for sickle cell, for instance. Then you're more likely to create a thrombus and embolus. With hypertension, you're probably more likely to just burst the vessels and cause a hemorrhagic stroke. So if we say that just by statistics, this lady has had an ischemic stroke, what do you think is the Bamford classification for this stroke, and why? So give me your reasons with your answers. It's difficult, isn't it? So she hasn't had an ischemic stroke, or if she has had an ischemic stroke, she probably has had a lacuna stroke. Okay, the only abnormality that she has in her case is the word finding difficulties. Yeah, so someone said lax. Yeah, perfect. So it could be a lacuna stroke, or given her hypertensive history, it's probably a hemorrhagic stroke. You can you can do a CT scan to see if you can figure out which kind of stroke it is. Okay? Does that make sense to everyone? Any questions? No questions? Everyone happy? At least say you're happy if you're happy. Yep, good. Okay, fine. Does she have a pure sensory deficit? So she has a higher function deficit. So she has a deficit just in her speech. She has a word finding difficulty, and that's about it. I don't see anything else in terms of weakness anywhere else. She has a higher cerebral dysfunction. Okay, so speech, visuospatial. So which type of lax does it fit? So I see why you're calling it a lacuna syndrome, but remember, Bamford classification is for ischemic strokes only. I hope I've convinced you that she's probably had a hemorrhagic stroke just because of her history. So you can't use your Bamford classification for that, because Bamford classification is for ischemic strokes only. Is that clear? Okay, cool. Moving on to another case. So I'll read it out at the same time. So 75-year-old man, sudden left-sided numbness, weakness, which was still present at the time of assessment in ED. Past medical history comprised of paroxysmal AF, so that means AF that comes and goes, which has been DC cardioverted. He was not taking any regular medication. He was a right-handed driver with no other past medical history. On examination, he had objective reduced power on the left side of his body, 4 out of 5. So that's the scoring system we use, remember? But no other abnormality. He was alert oriented. His NIH score was calculated to be 3, so that's a prognostic score. An urgent CT scan of the head was normal. So let's think about what kind of stroke this patient has had and what the risk factors are in this patient's history. Okay, good. So I think we can establish that this is an ischemic type of stroke. Can you guys tell me what the risk factors are? Yep. AF, age, perfect. We're getting there. Good, paroxysmal AF. So even though this patient has been DC cardioverted, we don't know if that's been entirely successful in terms of keeping his paroxysmal AF at bay. Main risk factor is his paroxysmal AF and also his age. He is a right-handed driver. So most likely and which side has he had his stroke? So he has reduced power on the left side of his body. Good, so he's had it on the right side. Brilliant. And so this is an ischemic stroke, so now we can use the Bamford classification. I'd like you guys to tell me which part it would fall under and how you would classify it and why. So give me a reason as well. Okay, I have a vote for lacuna, 2 votes for lacuna, 1 for partial. Any other votes? Keep coming. Keep them coming. That's it. Lacuna. I need why as well with your answers. Okay, great. So we read the yeah, so I think this is a partial anterior circulation stroke. So it's motor and sensory. So let's go back to our Bamford classification. So this man has unilateral weakness and or sensory deficit. Does he have a homonymous hemianopia or a higher cerebral dysfunction? Let's have a look. So we're over here. So he had left-sided numbness and weakness. No other past medical history. Reduced left side power. And he's alert and oriented. So actually, this sounds like a lacuna infarct, doesn't it? It could be a partial. We have to assess completely and make sure that it isn't, and then treat him accordingly. Okay, so I would say both teams here that have voted for lacuna and PAX could be equally real, but could be equally right. But at this point, I would vote towards lacuna just because he has numbness and weakness. We need to map out where exactly the numbness and the weakness is. So is it entirely face, arm and leg? We also need to see if he has any visuospatial problems or any higher cerebral issues, and that would help us rule completely in favor of one or the other. Okay, good job, well done. These are difficult cases. Okay, so I have 2 slides on knowledge check 4. So let's read this case. A 64-year-old right-handed man described 3 episodes of double vision, followed by vertigo and sudden onset numbness, weakness on the right side of his face and right arm. Each attack lasted around 10 minutes and was associated with a dull headache. He presented to ED after the third episode where he still had the symptoms. So what do we think's going on? Perfect. So the first two episodes were likely TIAs. We have an MS in the guessing. Okay, why do you think MS? To the person who replied that. Okay, let's carry on. What is the third episode likely to be? Yeah. So he's had a few TIAs, but he's now presented to ED, and we don't know how long after the onset, so it could be a stroke. Our threshold needs to be quite low with how we approach this. It could be a TIA as well, completely right, but it could be a stroke because of the risk factors that he has. So this is where the history taking comes in. You need to know what the onset is. You need to know what his symptom distribution is. It's not easy, guys. When you get questions on stroke in your MCQs, it seems quite clear cut what's happening. But you get patients like these in clinics and into ED where it's not actually clear what the patients come in with, and it's where your clinical judgment comes into practice. Okay, so that's why it's really important to train your history taking, to train your examination skills, and to have good anatomical knowledge so that you can figure out where the particular abnormality is. So I have a question. How often does a TIA become a stroke? I will answer that in a second. Could it be hemiplegic migraine? Could double vision be aura? So yes, it could be a hemiplegic migraine. So, but it's unlikely given the last few attacks. So the last few attacks last around 10 minutes. Migraines don't usually last such a short while. They last almost 72 hours at the max range. So those definitely sound like TIAs. The double vision right now, maybe, but it sounds like a posterior TIA, a posterior potential stroke that he's presenting with right now. I hope that sounds logical. Like an okay answer? Yeah? Yeah, great. Perfect. I'll answer the TIA to stroke thing. And this is a continuation of 4. So his past medical comprised of hypertension, migraine, and atrial fibrillation. He has never smoked, takes Rampril and simvastatin. On examination, weakness of his right arm and leg with incoordination of the right side and difficulty walking. Speech was normal. Examination of the eyes revealed horizontal nystagmus. Fast component would change direction when he looked to the right and then to the left. Stroke score was 4. Urgent CT of the head was normal. So where do you guys think the stroke is? Yeah, so people have correctly guessed that this sounds like a cerebellar or posterior circulation stroke. So you've got so I'm sure you guys have heard of Danish and equal acronyms, mnemonics for things. So he's got incoordination, which points towards the cerebellum. Difficulty walking. Cerebellar vermis tends to be trunk or ataxia, I believe, but you can fact check me on that. The speech was normal. Okay. The examination of the eyes revealed horizontal nystagmus, and these all point to a posterior circulation stroke. Yeah, perhaps even a lateral medullary stroke. So let's go back to our lateral medullary stroke. So we've got the ataxia, we've got the nystagmus, so it could be even in the medulla or the cerebellum. So we know roughly where it is. CT will help us better. A good history taking and a good examination would help us also. So from just the case presentation, so what you might get from the ambulance crew or the patient, you know that it's in the posterior circulation. History and examination will tell you more. And then finally, the location might be from the CT head. Here, the CT doesn't show anything, but the ischemic strokes and hemorrhagic stroke, mainly ischemic strokes, tend to mature with time. So you might need a second CT to show you exactly where the abnormality is. It unfortunately takes a bit of time for brain tissue to die, I guess, and therefore show up on CT heads. So yeah. So finally, my biggest take-home message is think about the anatomy when you have any MCQ question. Make sure you read the question properly, and then when it's history taking time, think about your onset and your risk factors. So those are the two main things. If you could fill out some feedback, I'd be very grateful. And in the meantime, I can answer the question about how often does TIA become a stroke. I think the number is around 40%, or the risk of having a stroke increases with TIAs by that much. You can again look up the numbers on in research papers. They probably have varying numbers for that, depending on kind of even geography and things like that. So yeah, I hope that was helpful. It was a whistle-stop tour. There is more about management of strokes that we can go through, and CT heads that we could go through. But I will stop there. Any questions from anyone? Brilliant. Thank you all for coming. Could you talk a little bit about management? So let's go through that briefly. Is that okay? Everyone happy to stay for a little bit and talk about management? Okay, so stroke management essentially depends on what stroke you have. Hemorrhagic strokes mostly are a result of very high blood pressures. So in that case, you want to decrease blood pressures. So that might involve using a beta blocker, such as labetalol, and other blood pressure medications to bring down those values to prevent you from bleeding out more, essentially. When you have figured out if the ischemic stroke, for example, is due to a thrombus, you can either do a thrombolysis or a thrombectomy, but you need to be pretty sure that it's a thrombus before you do thrombolysis, because if it was a hemorrhagic stroke, you'd just bleed out. So you can use clot busters or anticoagulation, essentially, like alteplase, for example, to bust a clot. And you don't want to just bleed out after that. Most people will get regular doses of aspirin, quite a high dose initially, 300 milligrams, and then they'll be put on aspirin lifelong. And depending on what the causes, long-term management may include statins or anticoagulation for atrial fibrillation or people who have increased risk of clot making. There could also be strokes because of problems in the carotid. So if you have carotid stenosis, you can throw off thrombi from the stenosis itself. So this is similar to having a heart attack, I guess. So you can have a carotid endarterectomy. So you only have carotid endarterectomies if the blockage within the carotid arteries is significant enough to cause symptoms, or if it's more than 70%. And the surgery itself can put you at risk of stroke. So yeah, so those are a few ways of how you can manage strokes. In the acute setting, think about what's causing the stroke and how you can minimize it. For example, as I said about hemorrhagic, you want to bring down the blood pressure, for example, and giving aspirin. Okay. I hope that's all right. Perfect. If you could all fill in the feedback, that'd be great. Thank you.